Welcome, everyone, to the Obesity Project. My name is Dr. Mark Shankman, and today, episode 34, Obesity in the Dental Chair, What I See as an Oral Surgeon That No One Talks About. So, hey, welcome, everybody. So, in my practice, I perform outpatient surgery every single day using IV sedation with patients breathing on their own. No hospital, no emergency room, no operating room, just me, the patient, and the truth. And I'm telling you, obesity and insulin resistance are changing the game. Most people think that the problem with obesity is only about how someone looks or what they eat. But I see what no one talks about: dangerously compromised airways, sedation risks, healing that stalls out, and infections that don't go away. This is the front line, and what I see might surprise you. Isn't just about teeth, it's about health and survival. Let me share a real case that brings it all together. So, I want to talk to you about James. James is a wake-up call in the chair. James is a 42-year-old male, about 5'8", 296 pounds, BMI of 45. And James is a protected name, so I'm not using the patient's real name. His medical history: has type 2 diabetes, has an A1C of 8.4, has high blood pressure or hypertension, obstructive sleep apnea, where he does not use CPAP, and obstructive sleep apnea is where you stop breathing in the middle of the night. And he's currently on 3 different diabetic medications. So the procedure we needed to do is a full mouth extraction with IV sedation in the office. And the sedation type is the type of anesthesia that I do on a daily basis. Um, IV sedation or IV general anesthesia without a breathing tube, so non-intubated, with spontaneous respiration, meaning they're breathing on their own without a breathing tube. And it's otherwise called monitored anesthesia care. And so I rely on patients breathing on their own without a breathing tube, no ventilator. And with James, that nearly became a disaster. So during a moderate sedation, James began snoring heavily and desaturated to about 89%. And what that means is they put a little monitor on your finger, and that monitor tells us how much oxygen is in the blood, right? And normal is anywhere between like 97 and 99. Pretty much if you desaturate or go down below 90%, we have to start breathing for you. And that's exactly what happened here. So he desaturated to 89% despite having nasal cannula oxygen. So oxygen going through 2 little prongs in the nose that you see on a lot of TV shows and whatnot. They put the straps around your ears and the little tubes go into your nose, providing a little supplemental oxygen. So we did a jaw thrust maneuver where we kind of push the jaw forward. The reason this works is when you thrust the jaw forward, the tongue is attached to that lower jaw and the tongue pulls forward and that opens the airway. So we had to do the jaw thrust. We repositioned his airway and a nasal airway was used, where we put a little rubber tube into the nose that goes down just beyond the tongue, not in, it's not a breathing tube, not into the airway, really just bypasses the tongue and gets us past any kind of blockage. But airway patency or his ability to breathe was very difficult due to all this excess redundant soft tissue, all this excess soft tissue around his jaw and around his neck, and he had a very, very thick neck. So in the office setting, there's no backup team. There's no intubation setup, other than for an emergency procedure. And although we have a lot of emergency meds, we don't have a crash cart like they have in the hospital OR. So, want to talk about some studies of obese patients. And obese patients have about a 300 to 400% higher rate of airway obstruction during these IV sedation procedures due to upper airway collapse or blockage, airway obstruction. And there was an article in the Anesthesia Pain Med in 2020. I can't even begin to pronounce the lead researcher's name, but It was in Anesthesia Pain Medicine 2020 that showed that a neck circumference greater than 17 inches is a key predictor of a difficult airway. And there are numerous other studies that support this. So we have a significant risk of emergency airway in the office. And so what if spontaneous breathing stops? In a hospital, you can call anesthesia. In my office, I am the emergency team, and my assistants are the rest of the team. So if James loses consciousness or has laryngospasm, which is a situation where the vocal cord snaps shut, trying to protect the airway, but under anesthesia, that slamming shut of those vocal cords prevents any air from going down the windpipe. So then emergency airway management becomes very, very risky because obese patients are much harder to mask ventilate. You know, when they put that mask and squeeze the bag, much, much more difficult to get a good seal and much more difficult to actually force the air into their chest because of all this extra weight. Even the weight on the chest, especially women with large breasts, makes it much harder to move the chest cavity and actually adequately ventilate the patient. Also, they have more limited neck mobility, so they can't maneuver their neck, can't lean their neck back as far. And excess soft tissue reduces the visibility if we have to put in a breathing tube or what's called laryngoscopy. And then finally, in a true emergency where you can't get in an LMA, a laryngeal mask airway, or a breathing tube, an endotracheal tube, then you have to go to a surgical airway called a cricothyrotomy. And that cricothyrotomy that you go, you've seen tracheotomies. This is a similar procedure, only more of an emergency procedure and quicker. A cricothyrotomy in a very thick neck and in an office setting is not ideal or likely to succeed very quickly. So a couple studies do support that obesity is a leading cause of failed emergency intubation in and out of hospital settings. This was found in the British Journal of Anesthesia in 2020. And even mild sedation, light sedation or conscious sedation, or what some people call the twilight sleep, can cause significant hypoventilation, inability for people to adequately get oxygen in and out or air in and out in patients with central adiposity. So meaning they carry a lot of extra weight, a lot of subcutaneous fat in the core region. And this was also found to be the case in a study in the anesthesia analog in 2016. Okay, so I got through the surgery, but that's when the next problem began. So James returned later after the surgery with delayed healing, dry sockets, and minor abscess formation at several of the extraction sites. And his blood glucose during the healing remained well above 180 milligrams per deciliter, which is very, very high. You don't want, ideally, you want it about 90, but you definitely don't want it above 100 milligrams per deciliter. And when you have blood glucose elevated to this level or hyperglycemia, elevated blood glucose, this causes neutrophil dysfunction and impaired angiogenesis. Sorry. So neutrophil dysfunction is white blood cells that are supposed to go in and take care of the healing, are not able to function properly. So these are white blood cells malfunctioning. And impaired angiogenesis means there's supposed to be new blood vessels that come into the area to promote healing. And with elevated blood glucose or hyperglycemia, you get impairment or inability to get those new blood vessels into the area properly. And we see this neutrophil dysfunction and the impaired angiogenesis in insulin-resistant patients that delays healing and increases infection risk. And we've got some studies to support this as well. Diabetic patients have double the rate of postoperative infections in oral surgery. This was found in the Journal of Oral and Maxillofacial Surgery in 2021. We also have found that poor glycemic control, blood sugar control, impairs fibroblast migration and collagen remodeling, which is crucial for socket healing. So let's break that down a little bit. Fibroblasts are the cells that actually lay down collagen, which is the basic ground structure or scaffolding that you need for connective tissue, for muscles, for tendons, ligaments, bone, teeth. All of these things require fibroblasts to come into the area, and poor glycemic control impairs that fibroblast migration and then collagen remodeling. The initial collagen that's placed down by the fibroblasts is not very well organized, and over time, those fibroblasts need to remodel it and generate it into a situation where there's lots of cross collagen linking, which makes the tissue much, much more stable and stronger and prevent wound dehiscence or opening of that wound. So this was also found, all of this, the poor glycemic control impairing fibroblast migration and collagen remodeling in the Diabetes Care Journal in 2013. So we keep treating the symptoms, but the root cause continues to be ignored. And what we have to realize is the real issue here isn't just sedation or difficult sedation or slow healing. It's the rising epidemic of metabolic disease driven by ultra-processed food, big pharma's reactive model, and a system that medicates instead of educating. So I'm a little over a month into the carnivore diet and cutting carbs, cutting out seed oils, processed junks. I've already seen the difference in my energy, my focus, and in inflammation in my body. So if we don't talk about insulin resistance, obesity, and food addiction, yes, you can be addicted to sugar and carbohydrate. We're just putting Band-Aids on the metabolic wildfire. So I'm not just a surgeon, not just an oral surgeon, I'm a doctor. And doctors should be looking upstream. What happens in my chair reflects what's broken in our food system and our medical model. This isn't about willpower, it's about a metabolic environment that's stacked against us. And if you're ready to fix the root cause instead of just treating symptoms, if you're ready to fix the root cause instead of just treating the symptoms, keep following because the next patient could be you. So thank you so much for watching. I wanted to get into this a little bit. This is obviously a topic that is near and dear to me. I deal with this on an absolute daily basis. We've got to do something about the obesity problem. We've got to do something about getting the medical profession to start to look through the proper lens. And the proper lens is looking at insulin, not at blood sugar. If we look at insulin instead of blood sugar, we'll catch hyperinsulinemia or elevated insulin levels decades before we start to see type 2 diabetes. And we can really make a difference in people's lives and in their health. So that's why I started on this crusade. That's why I started doing the Obesity Project. And that's why I will continue to educate. I will continue to teach what I can. I will continue to raise awareness and shine light on this subject. So thank you so much for watching. Like, sharing, comment. Make sure you share this with anyone else that you think would benefit from watching this video. I appreciate you. Make sure you subscribe, and I'll catch you in the next one. Take care. Thanks so much for watching.